Okay, this is the last lecture of the year. We're going to talk about psychotropic medications. These are the drugs that, as psychologists, you may be running into because this is what you'll be treating your patients with. This is what other psychologists will have prescribed for the clients that you'll see. So we're going to talk about all of these. I'm not expecting you to memorize all of these, but if we go through this and you see these medications the next time you see them, possibly when you're dealing with a client, you'll remember them. Anyway, okay, so we're going to talk about psychotropic medications. We're going to talk about the SSRIs first. Of all the psychotropic medications, Prozac was the most popular. Before that, it was Valium. So we're going to talk about SSRIs. They're not the newest antidepressant on the market. The newest antidepressants are selective norepinephrine reuptake inhibitors. But we're going to talk about, and we're going to talk about that. We're going to talk about the older antidepressants, tricyclics and monoamine oxidase inhibitors. But we're going to talk about all four of the major antidepressants. And of course, we're going to talk about all the other psychotropics as well. But this is the first one we're going to talk about. The mechanism of action. SSRIs inhibit serotonin reuptake so that they increase synaptic serotonin levels. Many SSRIs affect other receptors, especially at high doses, and those, of course, are the other neurotransmitters that they affect. The other receptors that they affect are dopamine and norepinephrine. SSRIs clinical effect usually take weeks, so the mechanism goes beyond simply increasing synaptic serotonin. There are several serotonin receptor sites. Another indicator of serotonin is 5-HT. Serotonin receptors are located throughout the body, especially in your gut, in your GI tract. All SSRIs except Luvox are FDA approved to treat depression, major depressive disorder, and dysthymia. Dysthymia, of course, is low-grade depression. Another name for low-grade depression. Various class members of SSRIs are also approved to treat generalized anxiety disorder. So normally when somebody has anxiety or a panic attack or depression, they treat them, one of the first things that they treat them with is probably an antidepressant to see if that doesn't take care of their problem. If that doesn't take care of their problem, then they hit them with stronger anxiolytics, anti-anxiety drugs. Obsessive compulsive disorder is another thing that we use SSRIs for. Post-traumatic stress disorder, eating disorders such as anorexia. Anorexia is very often caused by depression, or it's one of the contributing factors. So we try to take care of that aspect of the problem as well, and so we use SSRIs for that. Premenstrual dysphoric disorder, PMS, premenstrual dysphoric disorder is a worst case PMS, premenstrual syndrome, and social anxiety disorder, of course. Off-label uses, sometimes we treat ADHD with SSRIs. Insomnia, we can treat the depressive aspect of it as well as ADHD. Chronic pain syndromes, seasonal affective disorder, behavioral problems in individuals with dementia and intellectual disability. These behavioral problems, these are people that are usually institutionalized, and sometimes they will, especially with dementia, a lot of times they're suffering from depression as well. Same way with intellectual disability. If you have an individual with an intellectual deficit, then this sometimes depression is part of their problem. The half-life of these antidepressants, if you miss a dose with the short one, if you miss a dose, you're in pretty bad shape. My wife used to be on Effexor. And one time she went to a conference in Washington, D.C., and she forgot her pills. Effexor is a antidepressant, anti-anxiety medication mix that is used for women who have gone through menopause. And she forgot her effects, or well, it only took her 2 days before she was in really bad shape. So she found somebody. Actually, there was some. Her roommate was using the same stuff at the same strength, so she was able to catch a pill from her. Anyway, the short life SSRIs are Paxil and Luvox. The moderate SSRIs, Zoloft, Celexa, and Lexapro. And then the longer life one is the most popular, is the most popular antidepressant. Used to be the most popular drug in the world. It's Viagra now, but it's used to be Prozac. You can miss a dose, you can miss a couple doses, no big deal. It doesn't really bother you because it takes so long to get it into your system. Sometimes over a month. It'll take Prozac over a month for you to get a therapeutic level into your system. And of course, the half-life is fairly long, so you can go for a couple days without taking a dose. If you try that with Paxil or Luvox, of course, you'll be having problems after the second day. The side effects of SSRIs. SSRIs increase your serotonin level. Serotonin is the neurotransmitter that controls your sex drive in your hypothalamus. Testosterone is what gives you your sex drive, and it tempers the testosterone in your hypothalamus. So it decreases your sex drive, and it impairs your sexual functioning, and this tends to not resolve in time. So if you start taking SSRIs, a lot of times you'll have long-term sexual, your sex drive will be impaired. Other side effects: nausea, diarrhea, anorexia, vomiting. All of these increase with the dosage. The stronger the dosage, the more likely you are to have diarrhea, nausea, low appetite to the point that you don't eat, and of course you vomit. This one, of course, you go off Prozac or you go off Paxil or Zoloft, and it resolved in time. Sex drive thing doesn't. Weight gain, especially with Paxil. Another word for Paxil is paroxetine. After initial GI effects, then a lot of times, well, in the beginning, of course, it really affects your serotonin in your GI tract. So it causes diarrhea, nausea, and vomiting. After that goes away, it's just kind of like morning sickness. Doesn't take as long as morning sickness does, but after it goes away, then you start putting on the pounds fairly quickly. Other side effects: headache, dizziness, anxiety, especially with Prozac. Another name for Prozac is fluoxetine. There is a rash that you can get, insomnia. It sedates you, makes you feel lethargic. You sweat. The odd thing is the sweat doesn't have an odor to it. It's not like it increases your body odor. It just increases the amount of sweat that you're pouring out. It's mostly just salt water. You will start having vivid dreams, and this is one of the things people like about it. It starts giving you vivid dreams. It's kind of like LSD. LSD. People like going to bed because they have such vivid dreams. Tremors, dry mouth, especially Paxil, and of course that's paroxetine. Bruising, increased prolactin. Prolactin is a protein that enables females to produce milk. So they'll start lactating, as weird as that is, even though they don't have a baby, they'll start lactating. Drug-to-drug interactions: Luvox increases Prozac, increases Paxil, increases Zoloft, increases Celexa, increases Lexapro. In other words, if you're taking one SSRI, you cannot take another because it will increase. It will double the dosage, triple the dosage, quadruple the dosage. You need to be really careful that you only take one SSRI at a time. The interacting effects may be dose dependent, and of course that is the way it is with Zoloft. Zoloft is very frequently given to women who are suffering from postpartum depression. especially if it is anticipated that they're going to slip into postpartum psychosis, where they may do harm to themselves or their infant. So Zoloft is one of the moderate SSRIs, has a moderate half-life. Selective serotonin reuptake inhibitor levels tend not to be altered by other drugs, but can potentially increase levels that can inhibit your metabolism, the metabolism of certain drugs. Examples: Paxil will increase risperidone. Risperidone is a antipsychotic. Prozac will increase buspirone, which is an anxiolytic or an anti-anxiety drug, and then Luvox increases olanzapine, which is also an antipsychotic. So you need to be very careful as to which medications you're taking when you are taking your SSRIs. Cautions, suicide, and this is a big one that they talk about all the time. Suicidal ideations and increased suicide risk, especially with children early in treatment, but there is significant debate as to how young and how old. Or now we're not prescribing Prozac for adolescents anymore. When it first hit the market, we were giving it to anybody. But now that the suicidal ideations tend to be a lot worse for adolescents. We don't give it to children. We don't give it to adolescents anymore. And that's mainly because of the suicidal ideations that we see. What it does, it takes away your inhibitions. It's kind of like being drunk. Most people who commit suicide have been drinking alcohol before they kill themselves. This seems to be another situation that we see with selective serotonin reuptake inhibitors. It removes that inhibition, that block that you have to keep you from killing yourself, and of course, and that's a really serious problem, especially with people that are adolescents. If you're a post-adolescent, if you're a young adult, usually not nearly as serious, as long as you have your adult brain. People over 25, it works fine without as many suicidal ideations as adolescents. Serotonin syndrome, serotonin plus monoamine oxidase inhibitors, possibly lithium, that can cause serotonin syndrome. The individual suffers from, initially it's diarrhea. They have tremors, they have sweating, they feel restless. Hyperreflexia leads to a progression of symptoms if untreated. Then it leads to disorientation. Then they will become rigid. They'll develop a fever, which leads to a fairly high fever, which eventually will lead to a coma. They'll start having seizures, and that, of course, can lead to death. If you get serotonin syndrome, usually they take you off whatever the SSRI is that you're on, but it has a 10% mortality rate. They just drop very, very quickly into coma, seizures, and then death. So it's kind of dangerous. You need to keep a real close eye on what's going on with these patients. Many medications and substances have serotonin activity. Cough medicine, do not take your SSRI with cough, anything with dextromethorphan in it. That is your cough syrups. Fentanyl, which is 100 times stronger than morphine. It's an opioid. Do not take your SSRIs. It can potentially lead to an overdose. Meperidine, which is the opioid, the name for meperidine, of course, is Demerol. Sumatriptan, it's a migraine headache medication. St. John's wort is an herbal antidepressant. Prozac is not popular in Europe. They use St. John's wort instead. MDMA, any of the illegal drugs, MDMA, ecstasy, LSD, and of course any of your antidepressants. Citalopram, Celexa, has few drug-to-drug interactions. It has high serotonin specificity, and it's typical or less selective serotonin reuptake inhibitor side effects. Escitalopram, Lexapro, has no generic available. It is very simple dosing. So Lexapro is one of the SSRIs that is commonly used. Fluoxetine, another name for that is Prozac. Seraphim, Symbyax is fluoxetine with Zyprexa. It has a very long half-life, as we said before, and it has significant drug-to-drug interactions, and that's one of the reasons why if you're taking Prozac, you probably can't take any other psychotropic. Fluoxamine or Luvox is used to treat obsessive-compulsive disorder. Multiple significant drug-drug interactions, so you need to be careful if you're taking Luvox. Paroxetine or Paxil has significant drug-to-drug interactions. Some reports of associated weight gain, especially with Paxil. They tend to get kind of pudgy. Withdrawal symptoms with missed doses, so you need to be real careful if you're on Paxil not to miss a dose. Sertraline or Zoloft has moderate drug-to-drug interaction and multi-step dosing. Zoloft is a bit tricky to dose out. The atypical antidepressants, we talked about SSRIs. There are new antidepressants that are not or have less serotonin specific or affect serotonin differently than selective serotonin reuptake inhibitors. 1981, Desaril or Trazodone was discovered. 1989, Wellbutrin or bupropion. 1993, Effexor, Venlafaxine. 1994, Serzone or Nefazodone. Remeron in 1996, Mirtazapine. Serzone discontinued, although generics are still available out there. And we're going to talk about Serzone in just a second. There's a reason why they took it off the market. Duloxetine or Cymbalta, if you watch television, sometimes you'll see advertisements for Cymbalta. The mechanism of action for the atypical antidepressants, Effexor and Cymbalta, are both serotonin and norepinephrine reuptake inhibitors. Remeron has a serotonin subtype and norepinephrine activity. Trazodone and Nefazodone have different serotonin activity than SSRIs. Bupropion has dopamine and norepinephrine activity, and this is why they are the newer antidepressant drugs, the SNRIs. Indications and off-label uses, label uses. All typical and atypical antidepressants have FDA approval to treat depression. SNRIs have been shown to be effective on chronic neuropathic pain, something that we don't really see with Prozac or Zoloft or Paxil. Wellbutrin has been approved to treat nicotine addiction, as curious as that is. Wellbutrin can augment SSRIs to reduce SSRI sexual side effects because it increases the norepinephrine level. And it tempers the amount of serotonin that it increases. It doesn't really increase it that much. Remeron and Trazodone are used to treat insomnia. Both atypical antidepressants have many similar uses to typical SSRIs, Remeron and Trazodone. Wellbutrin, Remeron, Trazodone, and Nefazodone do not usually have associated sexual dysfunctions. Trazodone, of course, is Desaril. Desaril is the drug that they give to combat soldiers coming back from a war zone with PTSD. The problem is that they can't fall asleep. This is a problem that we saw this in Vietnam. The individuals have a hard time falling asleep, so they get drunk and they pass out, and then they can sleep. They don't have those intrusive dreams. Trazodone makes you jump over your first delta wave sleep. Now, the problem with Trazodone is that, yes, it makes you jump over your first deep sleep pattern, but you don't make it up during the night. So you wake up tired, as if you're not well rested. Venlafaxine Effexor is similar to tricyclics with less safety and side effect concerns. We're going to talk about tricyclics in just a second. Effexor has FDA approval for depression and generalized anxiety disorder and social anxiety disorder. It is an SNRI. Effexor activity depends on your dosage. Effexor has a minimal drug-to-drug interaction. Effexor has side effects with missed doses, and that's what I was talking about as far as my wife was concerned. She was taking Effexor because she was postmenopausal, and that's a normal thing that they give anti-anxiety and antidepressant. The reason she got depressed was because I went on a Fulbright trip to South and Central America in 2003, and while I was gone for 6 weeks during the summer, and while I was gone, she missed me so much that they put her on. You think I'm kidding? No, I'm not really kidding. They put her on Effexor, and then she had a hard time getting off of it. Duloxetine Cymbalta is an SNRI and has minimal dose dependency. Cymbalta is indicated for depression and chronic neuropathic pain. Bupropion or Wellbutrin, Zyban is another name for bupropion. Bupropion is a norepinephrine and dopamine reuptake inhibitor. Zyban is used, of course, to treat smoking addiction. Bupropion is a seizure risk in certain patients, especially in high doses. Bupropion's drug-to-drug interactions are not often significant, except you can't give it. Anytime you're taking MAOIs, you can't take any other antidepressant. Mirtazapine or Remeron is a complex serotonin that has norepinephrine alpha-2 antihistamine activity. Mirtazapine has receptor activity changes with changes in dose. Mirtazapine has a sedation and weight gain, especially at lower doses. Mirtazapine usage can have lipid abnormalities. Remeron has minimal drug-to-drug interactions, of course, except with MAOIs. Nifazodone or Serzone is rarely used due to irreversible liver toxicity. Nazodone was pulled from the market because of the liver toxicity by the manufacturer in 2004, but it is still available in generics. Some people swear by this stuff, so it's very popular. It makes you feel good. Not only does it make you feel good, but there's very few side effects with it. Trazodone or Deseril causes sedation, in other words, puts you to sleep, allows you to go to sleep. But as I said, you jump over your delta for sleep. It lowers your blood pressure. It causes you to have weight gain, and this is one of the complaints that the soldiers were having. That it just puffed them up real big. They didn't like it. Trazodone is used most commonly off-label for insomnia. Rare reports of sustained painful erection. Priapism is another name for painful erection, a prolonged erection. Has to be treated. You have to go to the ER. The problem is that if you stretch out those blood vessels too much, then you'll have it can lead to impotence. You don't have the ability to have an erection after that. So you need to be careful as far as trazodone is concerned. If you have a prolonged erection, then you need to go to the emergency room. It's nothing to celebrate about because potentially you can do yourself a lot of damage. Tricyclic. Okay, now we're going to talk about the other antidepressants, the older tier antidepressants. Tricyclic antidepressants describe a group of drugs with similar structure and function. We'll go into the abbreviation. 1958, it was developed. The first antidepressant was MAOIs, monoamine oxidase inhibitors, and then they came up with the tricyclics. Monoamine oxidase inhibitors, of course, have a really curious side effect. We're going to talk about that when we talk about the MAOIs. In 1958, imipramine failed investigation as an antipsychotic. So they developed imipramine initially as to work on schizophrenia and bipolar disorder. Didn't work. But then they found that it had antidepressant properties. In the 1960s, multiple other tricyclics were developed and placed into use. 1990s, significant reduction in use due to introduction of selective serotonin reuptake inhibitors, which have fewer side effects. The mechanism of tricyclic antidepressant action, there is norepinephrine, serotonin, histamine, muscarinic or cholinergic, and alpha adrenergic receptor activity in differing ratios. Anticholinergic activity leads to many of the side effects of these drugs. It is used for depression and similar spectrum of disorders as selective serotonin reuptake inhibitors. In the old days, it was tricyclics that were used instead of SSRIs. Luckily, of course, we developed SSRIs, so we didn't have to use them anymore. Tricyclics are especially helpful with chronic pain and depression, secondary to medical conditions such as AIDS. Side effects include enuresis, in other words, you wet yourself, narcolepsy, where you fall asleep at odd times, premature ejaculation, insomnia, migraine, prophylaxis, in other words, it gives you migraines. Blood may be obtained to monitor dose effectiveness. So you have to have your blood drawn about every month. They monitor you to make sure you're not getting a toxic level in your system. The mechanism of tricyclic antidepressants action, there's norepinephrine, serotonin, histamine, muscarinic. Wait a minute, we already talked about that. Wait a minute, what have I done here? Drug-to-drug interactions for tricyclic antidepressants. Tricyclics have multiple significant interactions in each direction with potentially serious consequences. Side effects for tricyclics for anticholinergic problems include dry mouth, constipation, blurred vision, and urinary retention, cardiac arrhythmias and conduction changes, orthostatic hypotension, puts you to sleep, and there is a problem with gaining weight. Cautions when taking tricyclic antidepressant medication. Overdose is frequently fatal. Patients with bipolar, it stays in your system for a long time. And this is one of the reasons why we have to draw your blood every month. We need to make sure you're not getting a toxic level. If you take 2 pills instead of 1, sometimes it will kill you because of all the tricyclics that you already have in your system. Patients with bipolar disorder may be pushed into mania or rapid cycling. Amitriptyline or Elavil is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects. It blocks your acetylcholine, and it's high in pain control. Amitriptyline is used to manage major depressive disorders, anxiety disorders, migraine headaches, and neuropathic pain. Amoxapine, Cindin, is high in norepinephrine activity, low in serotonin activity, has moderate anticholinergic effects, and low in pain control. Amoxapine works as an antidepressant rapidly, 1 to 2 weeks. It has been used as an antipsychotic. So if you're taking, we're taking Prozac, takes 4 to 5 weeks, 4 to 6 weeks actually, for it to get into your system. Amoxapine gets into your system very rapidly, 1 to 2 weeks. Clomipramine, nafranil, is low in norepinephrine activity, is high in serotonin activity, has high anticholinergic effects, it blocks your serotonin or your acetylcholine, of course, and high in pain control. It's used to treat obsessive compulsive disorders, depressive disorders, of course, panic attacks, and anxiety. So as you can see, a lot of these antidepressants are used not only for depression, but also for anxiety. Desipramine or norpramine is high in norepinephrine activity, low in serotonin activity. It has low anticholinergic effects and low in pain control. Desipramine is used as an antidepressant and is used, oddly, to treat ADHD as well. Doxepin, Sinequan, is low in norepinephrine activity, low in serotonin activity, has moderate anticholinergic effects, and low in pain control. Doxepin is used to treat major depressive disorder, anxiety disorders, chronic hives, as odd as that sounds, and insomnia. Imipramine or tofranil is low in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects, blocks acetylcholine, and moderate in pain control. It's used to treat depression, anxiety, and panic disorders, and aneurysms, wetting yourself. Meprodoline or Ludimil is high in norepinephrine activity. It's low in serotonin activity. It has low anticholinergic effects and moderate in pain control. Meprodoline is used to treat depression, anxiety, panic disorder, and pain, neuropathic pain. That's neuralgia, that's the nerve pain. Nortriptyline or Pamelor is moderate in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and moderate in pain control. Nortriptyline is used to treat depression, anxiety, ADHD, neuropathic pain, and to help in smoke cessation, Pamelor. Protriptyline or Vivactyl is high in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and low in pain control. Protriptyline is used to treat depression, ADHD again, and its energizing effect is used to treat narcolepsy, as weird as that may seem. And a friend in the service that took this stuff, Vivactyl, because he was narcoleptic. They boarded him out of the service fairly quickly, as weird as that seems. They don't want you getting excited and all of a sudden falling asleep when you're needed, especially if you're a medic. He was a lab tech. Trimipramine or Sermontil is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects and high in pain control. It's used as to treat depression, anti-anxiety disorder. It's used to treat psychosis. So this is one of the SSRI or the tricyclics used to treat bipolar disorder and especially bipolar disorder, but also schizophrenia. And it takes care of insomnia. Monoamine oxidase inhibitors, as I've talked about them being MAOIs, was developed in 1952. Was found with antidepressant properties in a process looking for an anti-tuberculosis drug. 1962, so that was in 1952. If you remember, the tricyclics were developed in 1958. SSRIs in the 1980s, but didn't really hit the market until the 1990s. 1962, investigation of a death from hypertensive crisis by someone ingesting tyramine-rich foods while taking an MAOI. This is something that you have to be very careful with, as far as the tyramines are usually food additives. It's a preservative, so you have to be really careful. You have to only eat fresh foods if you're on MAOIs. In the 1960s, institution of strict dietary restrictions of tyramine-containing foods and other interacting substances. In the 1960s, significant reduction in use due to introduction of tricyclics, which do not have severe restrictions of MAOIs. So the first real antidepressant they developed was monoamine oxidase inhibitors. Since there was this problem with any foods that use preservatives, they didn't take it off the market because they needed an antidepressant. They didn't have anything at the time, and they were SOL kind of until the tricyclics were invented. In 2006, a transdermal selegiline patch, MSAM, was used to treat depression, and it's an MAOI. So if you're using this stuff, you can't eat processed food, and you can't and you can't take any other antidepressant with it. Monoamine oxidase inhibitors. Okay, we already talked about that. I see what I did. Okay. I'm sorry. Okay, that's the same as the other one. The features of MAOIs. MAOIs are effective antidepressants for those who can adhere to necessary restrictions and tolerate many other side effects. And the biggest problem is food, and as you're going to see, there's quite a list of tyramines. Very long duration, requiring caution when mixing with restricted substances or medications. If you're taking MAOIs, you can't take anything else. You have to be really careful. Tyramine-containing food. Certain tyramines may be consumed in moderation. You can't eat cheese. You can't eat chocolates. Anything with soybeans in it. Hot dogs. Dry sausage. Caffeine. So you can't drink coffee, beer. I'm sorry, you can't drink coffee, tea, or any of the sodas. Most of the sodas, anyway. Can't drink beer because it has preservatives in it. Can't drink wine. Can't eat pickles. Can't eat olives. Anything that is preserved, you can't eat it. You have to eat only fresh foods, steak, salad, and that's it. I mean, you can't eat anything that is preserved at all. Anything in a package you can't eat. Drug interactions with MAOIs, multiple prescribed and over-the-counter medications can be potentially lethal. So if you're taking MAOIs, you can't take anything else. Serotonin syndrome with SSRIs and many others, and this is one of the reasons why you have to be really careful if you're taking a monoamine oxidase inhibitor. Available formations, phenylzine, another name for it is Nardil, isocarboxazid is Marplan, and tricyclocypromine parnate. I trip over that L every time. Similar medications, selegiline, aldopril. Selegiline is used to treat Parkinson's symptoms, but of course, if you've got somebody with Parkinson's symptoms and you're treating them with aldopril, they have to be real careful about what they eat. Selective B inhibitor at low doses, so restrictions are not critical. So if they're taking Parkinson's if they're taking aldopril, it's a kind of a low dose monoamine oxidase inhibitor. At higher doses, it acts like a typical MAOI, so there is need for restrictions. Recently available as transdermal patch MSAM to treat depression and not needing food restrictions at low dose, although still drug interactions. It's a reversible selective A inhibitor, not available in the United States, and of course there are no restrictions on MSAM overseas. Mood stabilizers are used to treat bipolar disorder. Many mood stabilizers are used to treat various seizure disorder types, migraines, chronic pain syndromes, aggression, impulsivity, augmentation of antidepressants, and antipsychotics. Other classes of meds are also used in bipolar treatment, usually in combination with mood stabilizers. Mood stabilizers are used in treatment of an acute mania versus prophylaxis and depression. Prophylaxis it means maintenance. It's a maintenance drug. Lithium, carbamazepine, and valproic acid. This is the mood stabilizer. This is the old tier mood stabilizers. Carbamazepine and valproic acid are both anticonvulsants. In other words, it stops your seizures. In 1949, lithium was recognized as an anti-manic. Lithium toxicity. In the same year, they started to put lithium in salt. Lithium is a heavy metal, just like sodium is a heavy metal. So instead of sodium chloride, making salt out of sodium chloride, they made it out of lithium chloride. But then they realized, whoa, wait a minute, we're having some real serious side effects here from salt. So they stopped doing that. They thought, they could keep people from being crazy by putting lithium in the salt instead of sodium. Didn't work. 1949, it's the year I was born. 1966, French researchers demonstrate valproate's efficacy in treating mania. So the French are the ones that discovered they have a lot of bipolar disorder. Everybody has a lot of bipolar disorder in France. Anyway, 1966, 1978, significant studies demonstrate lithium's efficacy in bipolar disorder. 1980, studies demonstrate effectiveness of carbamazepine in bipolar disorder. Okay. Lithium features, only mood stabilizer without significant anticonvulsant properties. Most bipolar disorder medication is, and they are anticonvulsants. They are what we use to treat epilepsy. Up to 70% response rate, which is pretty good as far as lithium is concerned, as far as medications are concerned. Demonstrated effectiveness in reducing suicidality, less effective in rapid cycling and mixed bipolar states. Full clinical effect may take up to 1 to 2 months. Serum levels guide dosing. Lab draw 8 to 12 hours after the last dose. Okay, so it's a heavy metal, so you've got to be real careful how much you get into your system. And you want a therapeutic dose, but you don't want a toxic dose. So when somebody's on lithium, we have to draw their blood fairly frequently. It's excreted through your kidneys, so this can be a problem. It can blow up it can blow out your kidneys if you're not careful. Minimal liver-mediated drug-to-drug interactions. Okay. Lithium side effects: fine tremors, weight gain, nausea, increased thirst and urination. More severe toxicities include coarse tremors, gait instability, vomiting, diarrhea, and confusion. Increased risk of toxicity with fluid or salt restriction, hot weather sweating, use of anti-inflammatory drugs, ACE inhibitors, angiotensin, receptor blockers, and diuretics. If you've got a heart problem and you're taking anti-inflammatories such as aspirin, or if you're taking a blood pressure medication, lithium is not the thing you want to take. If you're taking diuretics to squeeze the liquid out of your system, if you've got edema in some part of your body, lithium is not what you want to take. It may cause kidney and thyroid dysfunction, so there is a need for regular monitoring of your thyroid function. That's what TSH is for, and your kidney functions. That's creatinine and BUN. Blood urea nitrogen is what BUN stands for. Females are at much greater risk of lithium-related thyroid dysfunction than males are, as weird as that may seem. Another name for carbamazepine is Tegretol. It's used as an acute mania and bipolar maintenance. It's more effective than lithium in rapid cycling in mixed states. It's less effective in bipolar-related depression. Serum levels can be helpful in guiding dosage. Of course, it has to have cleared your system before you can have your blood drawn. Multiple significant drug-to-drug interactions affecting both other medications, reducing their levels, and other medications affecting it, increasing the carbamazepine levels. It induces its own metabolism, so may need to adjust dose over several weeks. And that's carbamazepine, the anti-epileptic medication Tegretol. Side effects of carbamazepine: gastrointestinal problems, nausea, constipation, diarrhea, appetite loss. Central nervous system effects: sedation, dizziness, unsteadiness, confusion. Benign rashes are very common. Catastrophic rashes are rare, but they do occur. Many possible this is especially a serious problem with kids. They'll get these catastrophic rashes and they can't control it because it stays in your system for a while. Many possible serious abnormalities in your blood count if we're looking at a blood smear. Your red count, white cells. What else are we looking for in there? We're looking for your platelets. So a lot of times we'll see a lot of abnormalities. May reduce sodium levels, and this is known as hyponatremia. Liver function abnormalities are rare but possible. Toxic metabolite 10 and 11 carbamazepine epoxide can create problems via drug-to-drug interactions with valproate, lamotrigine, and phenobarbital. It's independent of carbamazepine levels. It can be checked separately, the valproate, lamotrigine, and phenobarbital. The other older mood stabilizer is valproate. Another name is Depakote. It's actually valproic acid. It's an anti-seizure medication given to individuals who are suffering from epilepsy, but it can also be used with people with bipolar disorder. It can be dosed rapidly to treat acute mania. It is more effective than lithium in rapid cycling in mixed states. It is used by some to treat aggression and impulsivity and other psychiatric disorders. It is approved for migraine prophylaxis, controls your migraine headaches. Serum levels can be helpful in guiding dosing. Of course, you have to wait for 8 to 12 hours before you draw blood. Commonly used at top or above levels stated for seizure control. This is with the people with bipolar disorder. Some suggest supplementation with carnitine, selenium, and others to reduce side effects. Carnitine and selenium are both heavy metals. Valproic acid side effects: nausea, weight gain, unsteadiness, ataxia. It's another name for unsteadiness. Hair loss and tremors, liver dysfunction, decreased platelets. Another name for decreased platelets is thrombocytopenia. Pancreatitis, rare but potentially serious. Anytime you get pancreatitis, you don't want to blow out your pancreas. You cannot live without your pancreas. Polycystic ovary disease, suggested by some reports. Ammonia levels can be increased, particularly in those rare individuals with genetic metabolic deficits. Drug-to-drug interactions by various mechanisms with numerous other anticonvulsants, aspirin, and others. So you have to be real careful what you take your valproic acid with. Lamotrigine, oxocarbamazepine, carbazepine, topramate. Lamotrigine was investigated in the 1990s for mood stabilizing properties. These are the newer mood stabilizers. These are all anticonvulsants as well. They were developed as anticonvulsants. We were already using carbamazepine and valproic acid. Those are the older mood stabilizers, and these are the newer ones. Lamotrigine was investigated. It was already being used for people with seizure disorders in the 1990s. Most newer approved anticonvulsants were investigated for their mood stabilizing properties. Lamotrigine approved for bipolar I maintenance. It is thought that the newer mood stabilizers have less toxic levels, as we're going to see. Lamotrigine or Lamictal is minimally sedating, unlike most other mood stabilizers, and this is a good thing. Appears to be especially effective in treated bipolar depression, but unproven to treat mania. Early use as an anticonvulsant in children raised concerns about potentially life-threatening rash, the Stevens-Johnson syndrome, toxic epidermal necrolysis, kills your skin, and that's kind of a problem. Initiating lamotrigine is done very slowly to decrease rash risk. Valproate greatly increases lamotrigine levels, so you have to be very careful. Carbamazepine greatly decreases lamotrigine levels. So you can't, they tend not to use lamotrigine with valproate or carbamazepine because they never know what they're going to get. Oxcarbazepine trileptal is used primarily in combination with other mood stabilizers, although efficacy can clearly is not clearly substantiated. Modified carbamazepine with potentially less side effects and drug-drug interactions than carbamazepine. 1012 carbamazepine epoxide, not a metabolite, so higher doses required of switching from carbamazepine. Topramate, Topamax is research questions its use as a mood stabilizer, although there are scattered reports which suggest it has possible benefits. Weight loss, cognitive dulling, kidney stones, metabolic acidosis, not things you would want. Levetiracetam, efficacy in bipolar disorder unsubstantiated, although scattered reports suggest possible benefits, has minimal drug-to-drug interactions. Zonegran, zonisamide, efficacy in bipolar disorder unsubstantiated, although scattered reports suggest possible benefit. Side effects similar to topramate, including weight loss. Olanzapine fluoxetine combination, it's known as Symbyax. It's approved to treat bipolar disorder. Olanzapine is an antipsychotic, and fluoxetine, of course, is Prozac. Older antipsychotics. Now we're going to talk about antipsychotics. We've talked about bipolar disorder, the mood stabilizers. Now we're going to talk about older antipsychotics. 1950, chlorpromazine was synthesized as a sedating antihistamine. 1952, chlorpromazine reported to be beneficial in psychosis and mania. 1953, first reports of chlorpromazine-associated movement disorders. That's tardive dyskinesia. 1958, haloperidol was developed. 1962, long-acting injectable flufenazine was developed. 1970, dopamine hypothesis of schizophrenia was suggested. The dopamine hypothesis has to do with schizophrenia being caused by too many dopamine receptor sites. So if we can fill those dopamine receptor sites with something, then the person will stop having psychotic episodes. In 2005, the CATIE trial shows positive outcomes for perfenazine compared to newer antipsychotics. So we're going to take a look at the older antipsychotics. The neuroleptics were used. Neuroleptic means sees the neuron, refers to the tendency to cause stiffness and other neurologic symptoms. Early methods of dosing would achieve neurolepsis and then backdose down to relieve this effect. In other words, it caused them to be catatonic. They became stiff. Then they would take them up to that point, and then they would back them off until they had, of course, they were getting less neurolepsis, but still controlling their psychotic episodes. That's the neuroleptics. The major tranquilizers refers to the tendency to sedate, quiet, and create a blandness in patients, similar to the negative symptoms of schizophrenia. It differentiates from benzodiazepines, such as Valium, which were referred to as minor tranquilizers. Of course, give them a high dosage, and you got a major tranquilizer. Typical traditional conventional antipsychotics differentiates these drugs from newer atypical antipsychotics. Dopamine receptor antagonists highlights strong dopamine activity and tight binding at D2 receptor sites. We're going to talk about all these in just a second. Side effects, the terminology that we use when we're talking about the antipsychotics. This is really serious because these people are fairly socially non-functional, so we have to be really careful of the side effects that we're seeing. Extrapyramidal symptoms. Pyramidal symptom is responsibility for voluntary movement. The extrapyramidal system is responsible for involuntary muscle action. It includes dystonias, Parkinsonism, akathisia, and tardive dyskinesia. Acute dystonia is sustained muscular contraction of neck, eyes, and throat. Generally occurs soon after starting your medication. You have this acute dystonia where they move their mouth and their necks a lot, and they'll roll their eyes. Akathisia, uncomfortable continuous motor restlessness, can occur anytime in treatment, but generally in the first few weeks. It's easily misdiagnosed as underlying psychiatric disorder, so that can be a problem. It's a problem with the medication, and of course, they're seeing something more serious. Parkinsonism, tremor, muscle stiffness, slowed movement, drooling generally occurs beyond 1 week after starting medication. Tardive dyskinesia, spastic facial distortions and tongue movements may extend to neck, trunk, and extremities. Has a delayed effect, usually beyond 6 months from starting their medication. Risk increases with duration of exposure to antipsychotics. It's known to occur without antipsychotic therapy. May be permanent, occur in discontinuation, or resolve on its own. It's worsened by medications used to treat other extrapyramidal symptoms. Neuroleptic malignant syndrome, pipe-like rigidity, fever, tremor, altered level of consciousness, hypotension, tachycardia, laboratory abnormalities. They have elevated white blood count, and they have an elevated creatinine phosphokinase. Creatinine phosphokinase is a heart enzyme. Mortality is 10 to 20%. Can occur anytime in the course of treatment. So you need to be really careful about how you treat these guys. You're going to kill them. Anticholinergic effects, dry mouth, blurred vision, constipation, urinary retention, mydriasis, dilated pupils. Okay. So we have methods of classification. We're talking about the older antipsychotics. As you can see, there's just tons of really serious problems with this kind of stuff. Low potency antipsychotics, chlorpromazine, mesoridazine, medium high sedation, low medium extrapyramidal symptoms, and high anticholinergic effects. The medium potency for phenazine, loxapine, and molindon. Low-medium sedation, high extrapyramidal symptoms, low-medium anticholinergic effects, and the high potency are fluphenazine, trifluoprexine, thiazine, haloperidol, and pimozide. Medium to low sedation, high extrapyramidal symptoms, and low anticholinergic effects. And these are the old antipsychotics. Chlorpromazine, another name for it is thorazine. You may have heard of the thorazine shuffle. There's always a cardiac risk and a weight gain with thorazine. Fluphenazine or prolixine is long-acting injection is available with this stuff. Haloperidol, if you see somebody having a psychotic episode and they pin them down and they give them a shot, it's usually haloperidol. It's a long-acting injection, knocks them out fairly quickly. Loxapine or L'Occitane has no side effects. Serentil, mesoridazine has cardiac risks. Molindon or Moban has no effects. Perfenazine, trilofan has no effects. Pimozide, Orap has cardiac risks. Thioridazine, Mellaril has high cardiac risks. Thiazine, Navane has no risks, and trifluperazine has also called stelazine has no risks. The newer antipsychotic clozapine was introduced in 1990 in the United States after a long delay related to safety concern. 1994, risperidone was developed. 1996, olanzapine was developed. 1997, quetiapine was developed. 2000, ziprasidone was developed. 2003, aripiprazole was developed. 2004, ADA and APA consensus report on obesity and diabetes, and these in those taking antipsychotics. And this is a really serious problem. Here we're controlling their psychotic behavior, but they are gaining weight. They are gaining just buckets and buckets of weight. No muscle tone whatsoever. And they were developing diabetes, and we were killing them. The terminology of Neuro's antipsychotics, atypical antipsychotics, second-generation antipsychotics, serotonin dopamine antagonists. The mechanism that is used, it adds serotonin activity. It binds more loosely to dopamine receptors. Clozapine initially was rejected as an antipsychotic because of its seemingly reduced dopamine impact and lack of extrapyramidal syndrome problems. Indications and uses, schizophrenia and other psychotic disorders. It's used with those, acute bipolar mania and maintenance, augmentation of antidepressants and mood stabilizers, aggression, and impulsivity. One of the biggest problems we have with people who are suffering from psychosis, a lot of times they are overly aggressive. They have anger issues. They get angry. They have really serious problems. I was working in a rural health clinic in Oklahoma, and right outside of town was a place called the Agape Ranch. And in that ranch, they had people who were suffering from long-term psychosis. They had people who had severe intellectual deficits. It was a really nice place out in the middle of nowhere. The guy that ran the place was a former but he was a lineman for the Northwestern Wildcats from Evanston, Illinois. Anyways, big guy, about 350. One of his schizophrenia patients, patients suffering from schizophrenia, decided that they were trying to poison him, so he stopped taking his medication. This guy had no muscle tone whatsoever. Not that short. He wasn't that small. But he was fat. I mean, he had no muscle tone. And this other guy, he lifted weights all the time. Big guy, 350 pounds. Just a solid guy. Had a big beard. Anyway, this guy decided he was going to go off his medications because they were trying to poison him. And so he went off his meds, and he became violent one day. And of course, the big guy came in and tried to control him. He threw that guy through the wall. Sometimes aggression is more important than. Of course, the big guy didn't want to hurt him, but he threw him through the wall, literally through the wall. He busted through 2 layers of drywall. Of course, he threw him through the wall and almost knocked him out. So he's chasing this guy down the road, running like a deer. This fat guy with, he's just jiggling all over the place because he has no muscle tone at all. And he caught him, and he threw him through a fence. It was a 2x4 fence, threw him right through the fence. They finally sedated him to some extent. The way they sedated him, they promised they would bring him into the clinic, to my clinic. I didn't run the clinic, of course. I was the lab tech there. Anyway, they brought him into the clinic, and he knew me. We had seen each other several times, and he knew that I had been in the military. And for that reason, he thought that I had connections to the President of the United States. And once they told him that they were bringing him in to see Dr. Richards, to see the doctor, he mentioned my name, and because he had a message for me. And so that actually quieted him down more than any of the shots that they gave him. They hit him with Valium. It didn't really work. But he came in to see me. He wanted me to contact the president. Of course, this is in the 1990s when Bill Clinton was president. And he wanted me to contact President Reagan because President Reagan knew how to stop the communists from taking over the world. Anyway, long story short, we life flighted him out. The features of the newer antipsychotics, there's a less risk of extrapyramidal syndrome and movement disorders, greater effect on negative symptoms of schizophrenia. The negative symptoms are blandness and the loss of words and whatnot. The cautions with the newer antipsychotics, greater risk of obesity, diabetes, and lipid abnormalities, and can kill the individuals. Clozapine affects olanzapine, which affects quetiapine. Risperidone affects you can't add these things together. If they're taking one thing, you can't give them something else. It's not like bipolar disorder where you can mix your anticonvulsants. This doesn't work that way. Requires regular monitoring of metabolic parameters, potential stroke, mortality risk in the elderly, extrapyramidal syndrome, movement disorders, and NMS all can still occur, although much less than the typical antipsychotics. And this is a problem that we've always had with the antipsychotics is all of these side effects from the medication. Aproprazole, Abilify. You've heard of Abilify. Maybe you've heard of Abilify if you watch television and you watch the commercials when they're talking about all of these strange drugs. Abilify is a unique complex mechanism. Can be either activating or sedating. It causes nausea, and of course that's not something that they talk about in the advertisement. Clozapine or Clozaril, another thing that we see on television. Most effective antipsychotic. The risk of agranulocytosis, it reduces your neutrophils. Those are white cells that fight bacteria. So bacterial infections are something that you need to be careful of. Of course, you're checking for your white blood cells in CBC, a complete blood count. You're looking for white blood cells. You need to, when they first start taking clozapine, you need to check their white blood cells every week for 6 months. Then after that, it's biweekly, every other week, then monthly after a year. Multiple other side effects and drug-to-drug interactions. The levels are reduced by smoking, oddly enough. So a lot of times, remember, we've got one of the problems with people who have schizophrenia is they have too many dopamine receptor sites. And if these dopamine receptor sites aren't controlled, then the individual will have a psychotic episode. So one of the ways they do this, that they control it themselves, is that they chain smoke. When you smoke cigarettes, the nicotine gives you a dopamine spike. So every time you take a puff of that cigarette, you're actually controlling your psychosis. So a lot of times, and especially in the old days, these guys were chain smokers. They smoked all the time. They would wake up agitated. And the reason they were agitated is because they'd been asleep for 5 or 6 hours. So they would have to light up a cigarette, and then they would smoke all day long. And that's the only way they could control their symptoms. Another thing we see on television, Zyprexa, olanzapine, Zydis is another name for olanzapine. Significant weight, diabetes, and lipid abnormality risk, and of course the levels are reduced by smoking. These clozapine and olanzapine both control the D2 dopamine receptor sites, and that's how they control the psychosis. Quetiapine, Seroquel is approved dose range considered low by many. It has low extrapyramidal syndrome risk. It's used commonly as a sedating agent. Risperidone, this is a big one for the really severe people suffering from schizophrenia. Risperidone is another name for it. Most like typical antipsychotics at higher doses. It's available in long-acting injections called Consta. Ziprasidone, Gayadon is approved dose range considered low by many. Has initial cardiac concerns, appear insignificant for most people, but some people, of course, if they have any problems with their heart, this will cause problems. Must be taken with fat-containing meal or snack. So every time you give them ziprasidone, you have to give them, a fatty foods at the same time. Benztropine. We're talking about the anticholinergics. Benztropine or cognitin is the least sedating. It's most commonly used as an anticholinergic. Vicodin, Quinton is another one. Diphenhydramine, Benadryl. Benadryl, of course, is what you take if you have an allergic reaction to something to reduce the. It's an antihistamine, Benadryl. Arahexafenadil, Artane, amantadine, Simitril. It's not an AC, not an anticholinergic. It's used rarely to treat your extrapyramidal problems. Takes away the tremors, stiffness, drooling, dystonias, akathisia. May not respond to the anticholinergics. Tardive dyskinesia may worsen with the anticholinergics. Gives you dry mouth, constipation, and blurred vision. Extrapyramidal thought to be cholinergic dopamine imbalance. The benzodiazepines, Librium was developed in 1957. Another name for Librium is chlordiazepoxide. This is a muscle relaxant. What can I say? During Vietnam, of course, we used Librium and Valium in mass doses for wives of soldiers overseas in Vietnam. 1970s, Valium diazepine was a top-selling drug in the United States. 1986, Xanax, alprazolam was a top-selling drug in the United States. 1990s, SSRIs replaced some chronic benzodiazepine use for anxiety. Benzodiazepines, general characteristics, differ in action, duration, drug-to-drug interactions, and side effects based on differences in absorption rate, lipid solubility, and metabolism. Indications uses include anxiety disorder, panic disorder, mania, seizure disorder, phobias, insomnia, alcohol withdrawal, muscle spasms, agitation, catatonia, akathisia. Hospital use, you can put it in IVs or intramuscular, in sedation for procedures. So they'll give you a shot of Valium before they take you in. I had orthoscopic surgery done on my knee. Wasn't really bothered, but they gave me a shot of Valium before they took me in and gave me my anesthesia. They didn't knock me out. I don't know why they gave. Anyway. Yeah, everything worked out, and I didn't have any reaction to it. I don't think it worked. Side effects, it sedates you, get cognitive impairment, and anterograde amnesia, where you forget what's going on. You can't remember things. I didn't have any problem with it. Respiratory depression at high doses or with alcohol, so you certainly don't want to take your Valium with a bottle of wine. It may worsen obstructive sleep apnea symptoms in susceptible individuals. That's all supposed to be together, I guess. Abuse and dependence. Risk of abuse is small in individuals who are not abusing other substances. Withdrawal symptoms and physical dependence are not in themselves problematic if reductions are done gradually to minimize symptoms. Use of longer-acting agents to minimize between-dose breakthrough and avoiding taken-as-needed dosing are helpful. Symptoms of withdrawal may represent breakthrough of underlying anxiety disorder, needing to increase the dose if they develop too much of a tolerance. Not generally an issue at therapeutic doses. And we're talking about mostly Valium here. And here they are. Xanax, alprazolam is short to mid. It works short to mid. Chlordiazepoxide, Librium is works for a long time, stays in your system for a long time. Clonopin is mid to long, is serotonergic. Transine is long. Clorazepate. Diazepam, Valium, works for a long time. That's why we used to give the women Librium and Valium. Unfortunately, of course, both of these are very highly addictive. Prosom is a newer one. It's mid, lasts for a moderate amount of time. Dalmane, long, lasts for a long time. Ativan is a biggie, short to mid. It has minimal drug-to-drug interactions. Cirax, short to mid, has minimal drug-to-drug interactions. Restoril, mid, and has minimum drug-to-drug interactions. Halcyon is short, and this is one of the things that we give somebody if they come in and they're highly agitated. We'll give them a shot of Halcyon. It lasts for a short period of time. It just knocks them out for a short period of time. It sedates them for a short period of time. We can knock them out with this stuff. 1869, chloral hydrate was first used. Chloral hydrate is 4 molecules of alcohol stuck together. So if we wanted to knock somebody out, we'd give them chloral hydrate. This is how they used to Shanghai people. They'd drop chloral hydrate in somebody's drink and they'd knock them out. Sometimes they'd kill them because if they're drinking alcohol and they were a little bit drunk and they dropped this tablet in their drink, they'd get an overdose of alcohol and it would kill them. 1992, Ambien was approved. 2006, Ambien generic was developed. The hypnotic medications that they use, non-benzodiazepine anxiolytics, include buspirone and antihistamines. The newer anticonvulsants are used off-label as both anxiolytics and hypnotics, although efficacy is unproven. Trazodone and some tricyclic antidepressants are used as hypnotics to knock people out, put them to sleep. Sleeping pill. Newer hypnotics activate the GABA1 receptor except Ramelton. Miscellaneous buspirone or Buspar is a subtle anxiolytic. You get slow response with it. Chloral hydrate, Noctec, is a hypnotic, rapid tolerance, toxicity, and overdose. And you have to be real careful with chloral hydrate. So a lot of people don't take it. Who do we know that died with chloral hydrate in their system? It was Marilyn Monroe had chloral hydrate. Antihistamines, hydropoxine, pomate, Vistaril, and Benadryl, there you go, are the antihistamines, as I said before. Anticonvulsants, mildly sedating and calming, Neurontin, Lyrica, and Gabritril. Lyrica, of course, you've seen the commercials about Lyrica. Selective benzodiazepine receptor activity, GABA1, that are your hypnotics. Lunesta is long-term use approval. Lunesta is the one with the butterfly, the Luna moth. I'm sorry, it's not a butterfly. Sonata has a short half-life, and Ambien, of course, is another hypnotic that they use as a sleeping pill. Melatonin receptor agonist, Ramelton, and it blocks melatonin. Melatonin tells you when you should go to sleep or wake up. The stimulants, the ADHD drugs, 1956, Ritalin was approved as an ADHD drug. 10% of 10-year-old boys in the United States are on some kind of stimulant. Usually it's Ritalin or Adderall. 2.5 million children in the United States are on stimulants. Recent FDA warning about increased cardiovascular risk, sudden death for patients on stimulants. Strattera, non-stimulant treatment for ADHD. Recent caution about suicidal ideations with Strattera. Rare liver function impairment, and that's what we give our kids to control their ADHD. Clonidine or Catapress has antihypertensive alpha-2 agonist. It's used for ADHD, substance withdrawal, Tourette syndrome, and other things. Cylert, of course, pimeline is rarely used stimulant due to liver toxicity, so we don't use that nearly as much as we used to. Dexedrine, multiple long-acting forms. It causes insomnia, headaches, tremors, exacerbation of tics, nausea, weight loss, blurred vision, and overstimulation. Methylphenidate, Ritalin, has the same effects, so you have to watch your kid for all of these problems. Provigil, metaphenyl, is a non-stimulant. It's a poorly understood mechanism of action. We're not exactly sure how it's used. It's used for sleepiness related to narcolepsy, obstructive sleep apnea, depression, and multiple sclerosis. It's used for ADHD. We're trying to figure out if it really works. Medications for dementia. Cognex, Tacrine was approved in 1993. Aricept in 1996 was approved. 1997, generalizability of approval studies was questioned by the Journal of the American Gerontological Society in 1997. 2003, Namenda was approved for moderate to severe Alzheimer's dementia. 2004, detailed British study questions efficacy of cholinesterase inhibitors. The problem is, of course, the dopamine-producing cells in your brain go away. No, I'm sorry, the acetylcholine-producing cells in your brain die. So what we try to do is increase the amount of acetylcholine. That's what Cognex and Aricept and Namenda do. They increase the acetylcholine in your brain. General characteristics of these anti-dementia drugs. The search for treatment for Alzheimer's dementia is driven by intense human suffering and immense demographic numbers. Studies that support use of these medications generally find subtle benefit or slowing of decline. They really don't increase the amount of acetylcholine, they just slow the decline, is what happens. They seem normal for a while because it increases the amount of acetylcholine, but the cells still die. There's no way we can slow down the death of those cells. There's a significant debate about the benefit versus the cost, money, and side effects of using these medications. Treatment for behavioral issues in dementia has been complicated by FDA warnings about the risk of using antipsychotics in the elderly. It accelerates the whole process. Cholinesterase inhibitors address one theorized mechanism of this complex disease. Aricept, Reminil, Exelon, Cognex. Cognex has a problem. It destroys your liver, so that's one of the reasons we don't use it. Namenda, complex activity. I can remember when Cognex first came out. I was working in a clinic in a rural health clinic in Oklahoma, and there were people that were coming and begging for this stuff. Complex activity via NMDA glutamate-mediated receptors may have more broad psychiatric applications. Meds to treat substance abuse. The use of medications in substance abuse treat withdrawal symptoms, benzodiazepines, anticonvulsants, and clonidine. A lot of times people who are going through withdrawals, a lot of times they'll go into seizures, and this is one of the things that we need to do. We need to give them anticonvulsants. Treat comorbid psychiatric disorders. Anxiety and depression are common. A lot of times that's the reason they're drinking alcohol. Both primarily in secondary etiologies, SSRIs, mood stabilizers, and benzodiazepines. We're trying to prevent relapse, craving control, and deterrence. Antabuse is a deterrent. It requires motivated patient. Antabuse makes you vomit if you drink alcohol. Camprol is craving control. The dosing is kind of interesting. Minimal drug-to-drug interactions. Efficacy in some studies is shown in some studies with more severe alcoholics, although other studies question its efficacy. Camprol. Naltrexone, of course, we know about. It's an opioid antagonist. The combined study demonstrates effectiveness in reducing relapse of medical management. High response for placebo cause, some to question study design. We're always getting placebo effects with things. Potential liver toxicity, of course, with naltrexone, so you can't take it over a very long period of time or you blow out your liver. Vivitrol injectable naltrexone lasts for 30 days, not part of the combined study. Buprenorphine, naloxone, Suboxone treatment for opioid dependence contains both an antagonist and an agonist. Bupropion, Zyban is identical to Wellbutrin, of course. It treats nicotine cravings. Others, several anticonvulsants, topramate, have been used for craving reduction. The uses of these drugs are off-label. Psychiatric uses of antihypertensive. The uses of these drugs are off-label and carry additional potential side effects for their cardiovascular actions. Potential psychiatric benefits have often been discovered while these agents are used for their primary indication. Monitor to use, of course, you have to monitor your blood pressure. Make sure it's not getting too low. And alpha adrenergic agonists, clonidine, quanfacine, prazosin is used in ADHD, Tourette syndrome, PTSD. Prazosin is found helpful in reducing PTSD-related nightmares. Beta blockers, propranolol, Inderol is used for akathisia, lithium-induced tremors, performance anxiety, and aggressive behavior. Pendolol has been considered for antidepressant augmentation, multiple drug-to-drug interactions, avoidant asthma, diabetics on insulin, certain cardiovascular diseases, beta blockers, calcium channel blockers, diltiazem, verapamil, and nimodipine. I'm on a calcium channel blocker and a beta blocker. May be helpful as additional agent in bipolar maintenance, multiple drug-to-drug interactions and depressions, and that is the end of that. Okay, this is the last lecture. Only one lecture for this week. Sorry it took such a long time. Fascinating stuff when we're talking about pharmaceuticals rather than drugs. So thank you. I had a good time. I'll see you next semester. I will be teaching from home. So all of you have, get all your stuff done, give me your paper, and we'll all be happy. Thank you, and that is the end of the lecture.